And those who've joined me previously will know that the simple plan is that I show an H&E slide, which has been scanned on my screen, and I give you a history, and then I hope and anticipate you giving me differential diagnoses, which we talk about that, and any other investigations that come up. We talk about any aspects that do come up, and that's the way we proceed. So it's a simple interactive procedure, which helps helps a two-way communication. Now, for future purposes, the slides through Lydia and Ava will be available for you to preview, which I'm hoping will give you a chance to look at these slides, the scanned slides online, and then be able to have a broader differential diagnosis. So that we're hoping will happen within the next month or so. So that's just to give you a preview of where that is going, because those slides will be scanned within the next couple of weeks. And at the next meeting, we hope that you'd have that chance to preview them. I chose, well, these are cases that I have in slide sets. So all I do is just go through them with you. And I don't necessarily choose them at this point for this conference. I just go through my slide sets. And where we stopped the last time is where I continue. And this is a adult male with a C7, cervical 7 vertebra and soft tissue. So this is a lesion tumor that involves the soft tissue adjacent to the vertebral body. And this is what we received. So I'm just showing you the different components to this, and I'll go down on high power. You can appreciate the nodularity, multi-nodularity of these. That's what I like to do, is give you a description without giving any clues to the diagnosis. And I describe this area probably is a good place to start. You can look at these areas here, which are fibrotic. It's just the pink fibrous tissue. You can appreciate some of these vessels. And then what we'll do is scan across to the more cellular areas, like here. And here I'm just going on higher power just for you to view this. You can see the rich vascularity and the cells, little ovoid, spindled. And if I can show them to you on higher power, you can see some of them have little nucleoli with some tapered cytoplasm. And most of them look ovoid in this field. Some of them are spindled. And that's pretty much the nodule that we're talking about, this multinodular areas that are hypocellular and a lot of fibrosis, and other areas that are still cellular, like you see here, with this rich vascular pattern. And that probably is the same picture we'll see in all the nodules. Here, if we look at the periphery of this nodule, you can appreciate more spindling of these cells. Okay, there are no mitotic figures. There's no atypia that we can see. There are little nucleoli though. And these merge with these more fibrotic areas and literally hypocellular areas. Okay, the location of this is very unusual, but it has been described in these sites. But given the location, it does make for interesting thoughts and ideas. Any thoughts and ideas, anybody? Whilst I show the other section, which you can see on low power, again, nodular, periphery more cellular, and the central much more fibrotic. And here again, the cellular areas.
Hi, Prof.
Hi, Carla. How are you?
I'm good, and you? I hope you are well.
I'm well, thank you. Nice to hear you.
Yes. I see the prominent HPC like vasculature. I don't know if it's a clue. And I'm thinking, let me just start off with the most common things like solitary fibrous tumor. I don't know if I also thought
Yeah,
of a myopericytoma.
yeah.
Um,
Both those are very, very
so,
good thoughts, Carla. Yeah.
but
Let's take each one of them. The solitary fibrous tumor is a very good thought given the vasculature that you speak of here, the hemangiopericytomatous vasculature, or like now more commonly used staghorn vasculature. People use the term staghorn vasculature. And your thought that could this be a solitary fibrous tumor is a very good one. There are hypocellular areas, and it's rich in vessels, and there are spindle cells. And the easy way to rule that out is with CD34, because solitary fibrous tumors are typically CD34 positive. And if you have a marker, it's not new, but it's been around now for over 5 years, as I recall, STAT6. And STAT6, as you know, is an expression, an overexpression because of the fusion between NAB2 and STAT6. You get overexpression of STAT6. So, Carla, those were negative here, and we did those because of the differential you mentioned. Could this be a solitary fibrous tumor? So both CD34 was negative and STAT6 was negative. The other differential you mentioned is also very good, thoughtful one. You mentioned myopericytoma. Let's broaden that. And perhaps think about that as a perivascular myoid tumor. And the perivascular myoid tumors, of which myopericytoma is one of them. And those can have staghorn vasculature. Typically, the myopericytoma has these onion skinning where the spindle cells form these onion skinning appearance around the vessels. This doesn't quite have that pattern. Uh, and also, just for confirmation, the immunohistochemistry for myopericytoma, or if we use the genetic term perivascular myoid tumors, those are actin positive. They typically actin positive. Some of them do have some genetic abnormalities that have been described, which I'm not going to go into, because you don't really need any genetic confirmation for the perivascular myoid tumors. All you need is some immunohistochemistry, depending on which tumor you're talking about. Now, I'm happy also, Carla, that you mentioned both benign tumors, because this is benign. This tumor is benign, and you know, I'm happy that your differential in thinking is along benign lines. So the actin was negative, CD34 negative, and the STAT6 negative. So we got those covered. Any other thoughts? What if I told you that this was from the digits, from the extremities, say an acral distribution involving fingers or toes? Would that help? Or palm or wrist? Let's look at these multinodular areas with fibrosing areas, and then these more spindling. Any other thoughts? You all familiar with the entity of fibroma of Tenergy? And this in the fingers and toes would be called a fibroma of Tenergy. This particular tumor is a little more cellular, and some people call it a cellular variant of a fibroma of Tenergy. And these are the features of it: multinodular with fibrosing areas and these much more spindled areas. These spindle areas are very bland, there are no mitotic figures, and they may sometimes have these cleft-like spaces as well. So when you read the textbooks, they talk about these cleft-like spaces around these tumors. Okay, you can see them here as well. And that's what I call this. I call this a fibroma of tendon sheath, a cellular variant. Now, if you look at the books and if you look at the USP6 rearranged tumors, that's the ubiquitin specific protein. That's a gene that's been rearranged in, as you know, nodular fasciitis and aneurysmal bone cyst, to mention just two. This tumor is also rearranged. The fibroma of tendon sheath, the cellular variant, also carries a USP6 rearrangement. So I throw that in just as a molecular confirmation for you to know that the USP6 rearranged tumors are quite varied. I mean, if you think about the aneurysmal bone cyst, which is an intraosseous tumor, they can occur in soft tissue as well. And there's a solid variant as well. Nodular fasciitis, which has nothing to do with ABC. And then this lesion, a fibroma of tendon sheath, is also a USP6 rearranged tumor. So that's what I call this, a cellular variant of fibroma of tendon sheath. Any questions or comments? Happy to take in any thoughts. Okay, we'll move to the next one. 37127. Okay, it's right there. It follows up there. All right, so another tumor, soft tissue, thigh, 58 male. And as you can see here, this is a section which shows a very well circumscribed tumor. We can start at the top, and just to demonstrate the nice circumscription, we ink all of our tissues. So that's the black ink. And again, you can see these spindle cells, okay, which come in two sort of patterns, these short fascicles with these myxoid areas, and then these more sclerotic spindle cells here. So fibrosing or sclerosis, fibroblastic, they all mean the same thing. It's just different descriptive terms. So you can see these alternating fibrosing areas or sclerosing areas with these loose myxoid areas as well. No particular pattern that I can see so far, but as we move along, you may argue that, and again, I'm not giving you this pattern to put you into any differential diagnosis. You may argue this looks a little storiform. I won't disagree. Yeah, you can see a very thick collagenous band here as well. And that's pretty much the picture throughout this tumor. Okay. These are the spindle cells. Again, very bland looking, plump spindle cells. Some of them are spindled and very thin, like here, more sclerotic, the most sclerotic areas. And then these alternate with these loose myxoid areas. Here you have a hyalinized vessel as well. And Carla, if you're thinking that this might be another SFT, you know, it's fair enough to think that. And I'll give you right off the bat that the STAT6 is negative in this case. So when you're confronted with these tumors, you have to resort to a panel of immunohistochemistry. And when you see hyalinized vessels like this, yep, you're going to think of SFT, but STAT6 is negative. What I will give you is CD34 is positive. So it's diffusely CD34 positive. Again, you can see these bland spindle cells here as well. I've been describing more sort of fibrous areas and fibroblastic areas, but I don't want to mislead you. Yeah, you can see a short fascicle of these spindle cells as well. Any other thoughts? So it's a spindle cell tumor of soft tissue, very bland looking. Dare I say it looks benign? I think it is benign. There are no mitotic figures. Spindle cells are very uniform. Some of the vessels look a little hyalinized. And there are these sclerosing areas. And some of these vaguely look whirling with a whirling pattern. Some of them may look a little palisading. Again, not using these terms to give you any differential, but you can see these vague patterns here as well. Any other thoughts? Yeah, some of these almost palisading, yeah, almost. I don't want to say Verocay-like, but it does look Verocay-like. Any thoughts?
So, hi, Prof.
Hi.
Was it a deep-seated lesion or superficial lesion?
That's a very good question. I've got
Was it-
thigh here, and I don't have that information. Let's say it's superficial color for our discussion purpose, and it measures 3 centimeters. What are you thinking?
Can it be a low-grade fibromyxosarcoma?
Yeah, that's a good thought. That's a very good thought. You've got spindle cells and you've got the sclerotic areas. When I see myxoid areas in a spindle cell tumor color, I always do the MUC4, always. So we did do the MUC4 here, and MUC4 was negative. MUC4 was negative. So again, just looking at spindle tumors here, bland looking with this variegated pattern with small foci of myxoid areas, other foci of more sclerotic areas. My approach generally is to ask myself, is this fibroblastic? And then, like you mentioned earlier, Carla, SFT comes to mind. Could this be a solidly fibrous tumor? We've ruled that out because STAT6 is negative, but we did say CD34 is positive, just to help you along that way. Then I asked myself, well, could it be myofibroblastic? In which case, I'd like to see some actin positivity. So if it's myofibroblastic, this is in the thigh, male. And if it's proximal thigh, you probably may think of things like myofibroblastoma, in which case you'd want Desmond to be positive. CD34, we already said, is positive. And then you'd want an estrogen receptor, which are very useful in myofibroblastoma. If you wanted to get a little more in-depth investigation, you could do the RB1. And RB1 is lost in myofibroblastoma. There's retinoblastoma 1. So that's helpful as well. So we've got fibroblastic, we've got myofibroblastic. And then I asked myself, could this be nerve sheath? And nerve sheath, like I said, there was some palisading. I think there's some whirling and there's some hyalinized vessels. So the simple way to rule in or rule out nerve sheath is to do the S100. I always like to do them in pairs. So I do the S100 and SOX10 to cover both those options. This tumor is negative for both S100 and SOX10. By the way, it's also negative for MUC4, which we've mentioned, and ER and actin as well. So as I'm going through those are negative markers as well. So the idea is when you see spindle cells, soft tissue, if it's benign, then is it fibroblastic? Is it myofibroblast? Is it nerve sheath? When you're thinking nerve sheath, if there's myxoid areas, yes, you have to low-grade fibromyxoid sarcoma and then do the MUC4. If it's in an appropriate location and has sweeping fascicles, then I do the beta-catenin for fibromatosis. This one's a little too cellular. The pattern here is short fascicles. This is not the long sweeping fascicles of fibromatosis. So I'm not too worried about fibromatosis here as well. If you did it, I wouldn't be too upset, but that's fine. I personally would not do it because the pattern is not right and the cellularity is not right. But I want to go back to nerve sheath. So when you think of nerve sheath tumors, we mentioned some areas looking a little verrucae, a little palisading. Then you ask yourself, well, is it a schwannoma? S100 SOX10 will help rule that out. Schwannomas are rarely CD34 positive. I've seen them being 34 positive, but they're very rare. Neurofibroma is more often CD34 positive. So this is 34 positive, but SOX10 and S100 are negative. So unlikely to be a cellular neurofibroma, even though the CD34 is positive and neurofibromas are positive. But the reason I'm going through this step by step and giving you a thought-provoking differential is don't forget perineurioma. It's also a nerve sheath tumor. And that's what this is. This is EMA positive and GLUT1 positive and CD34 positive. All the other markers for fibroblastic, myofibroblastic, and nerve sheath tumors are negative. So when you think nerve sheath, always include perineurioma. And if you have a GLUT1, which is useful marker, and you can use that, and EMA, which is also a membranous marker. So we sign this out as a perineurioma. It's a little cellular, little fibrosis, but entirely benign, and we ruled out all the other differential diagnoses. And sometimes you find these, there's a nice one here, this sort of whirl looking, right? WHORL, whirl-like pattern, which you see with this loose stroma in perineuriomas. That's a useful feature as well. those whorls. And I like that. And you pick them up. Now, if you're thinking perineurioma, then always ask yourself, well, could this be a hybrid tumor? And we, when I say we, my fellow Ahmed Lazim was finishing up with us this week. We always do all three markers for neurofibroma, schwannoma, as well as perineurioma, because sometimes you pick up these hybrid tumors where you have mixed neurofibroma and perineurioma, or mixed schwannoma and neurofibroma, or mixed schwannoma and perineurioma. So keep that in mind. It's always neat to pick up those, and you can pick them up on a low power pattern as well. Here we see the pattern pretty much the same all over. There isn't any changes in the morphology or the pattern. So it's very uniform and unlikely to be sort of hybrid. Here again, Carla, just to come back, that MUC4 you wanted would be very useful, and we did do it. We did do it. That was negative. I have a deep respect for low-grade fibromyxoid sarcoma, and the MUC4 always helps me in that regard, and that's positive. And we typically would then resort to FISH analysis to confirm the fusion. And the partners either FUS1 or EWSR1. So FUS usually in low-grade fibromyxoid. So perineurioma, don't forget this when you think of nerve sheath tumors, and then further, don't forget the hybrid tumors. Any questions or comments? Very happy to explore them with you. Okay, everybody's happy. How about this tumor here? This is a paratesticular, 2 centimeters in a 51-year-old male. Again, very well circumscribed. Again, I did not deliberately pick all these sclerotic tumors and spindle cell tumors. These just fall into place as I see them. They go into the seminar box. So here, again, just to show you that the morphology is similar all the way through. There are these vessels and pink sclerosis, fibrosis. And then the vessels, yeah, very tiny and very small. Yeah, I'm going to show you these vessels. The capillary-like size of, okay, and the spindle cells look very bland. And here you can even see some mast cells. Again, not trying to deceive you. Maybe a mast cell, I'm not sure. But here you can see spindle cells, not with any particular pattern, but you can see this wavy sclerosis. And here's these nice capillary size vessels. Not all of them are capillary size. Here you have some of them which are a little more thick-walled, a little more muscle here as well. Okay, and remember this is paratesticular. Little loose tissue here, so just to bring colors, CD34 and STAT6, just to get that out of the way, because you always want to rule out SFT, and this is no different as well. I definitely do the CD34 and STAT6 here to rule out solitary fibrous tube. I will give you that the CD34 is positive, and if this loose matrix you thought, okay, we probably need a MUC4 here, you could do that as well, and that's negative as well. But we do have CD34 positive. We have vasculature, which are these smaller vessels, and I showed them to you on higher power. And then I showed you these spindle cells without a particular pattern. When I was a young registrar, we used to use the word higgledy-piggledy, and that's what these nuclei look like. They don't have a particular pattern. In SFT, salty fibrous tumor, they use a patternless pattern. There's these vessels popping up again. Okay. The reason I keep showing you these vessels, because everybody's quiet, nobody said anything. Let's give you another clue. These vessels are hyalinized as well. These small capillary size vessels are hyalinized. And if you go and look for them, wherever you go and look for them, you'll see that. You'll see the nice hyalinized little vessels with this very bland spindle cells. Okay, so we talked
Yeah, I don't know if just the nerve sheath. Can we S100 SOX10? Is it
negative
was
color. Okay,
negative? Oh,
yeah. Of that fibroblastic,
okay.
we got the
Smooth,
SFT out of the way.
smooth muscle.
Smooth muscle, actin is negative.
Actin.
Actin is negative, desmin is negative.
And it's fairly circumscribed.
Very well
Very
circumscribed.
well circumscribed.
Yeah, and paratesticular. And I said male, so it's paratesticular.
Cellular angiofibroma.
Cellular angiofibroma, it is spot on, spot on. That's exactly what it is. And the reason that I put this in is because of the small capillary size vessels, they're hyalinized. The spindle cells are very bland. They're CD34 positive. These are also RB1 lost. Your differential diagnosis would be a myofibroblastoma, except the actin and desmin are negative here. In the myofibroblastoma, desmin's pos, so is CD34, and then ER is pos. These also have variable ER positivity, and that was positive in this, even though he's a male. It's also to emphasize that the mesenchymal tumors of the lower female genital tract, i.e. angiomyofibroblastoma, cellular angiofibroma, myofibroblastoma, and even the superficial angiomyxoma can occur in males as well. So they're not unique to women. They can occur in males as well. And in this instance, where you have the cellular angiofibroma, they can be ER positive as well. So they mark identical to those that occur in women. And this would be a nice example, a really classic example, because of those capillaries, hyalinized, small, and then these spindle cells. The cellular angiofibromas can vary in cellularity. This doesn't look very cellular. You may argue it's not very cellular. And you would be correct. It's probably more sclerotic and a little older, if you like, and probably lost some of its cells. But that's exactly what it is, a cellular angiofibroma here, just to show you these nice hyalinized capillary sized vessels. And increasingly, we've recognized these in men as well. And whenever I see one of those previously known GYN, lower genital tract mesenchymal tumors, and if I see it in a man, then I always put it in. Remember, it's not confined to the vulva or the vagina. You can also see it in the cervix, and you can see it in men, paratesticular. You can also see it in the groin. And sometimes you can go slightly higher up. You can see them. Remember also that the myofibroblastomas follow the milk line. They were first described in the breast. And strictly those in the genital tract are known as extramammary myofibroblastomas, strictly. I don't necessarily use that term, but here I'm just showing you these high power hyalinized vasculature, just the small, tiny little vessels. They're beautifully hyalinized, just to show you that. So CD34 pause, ER pause, RB1 lost, because these have the 13q deletion for RB, which is lost. So we've talked about two tumors that have RB1 loss. Today, we've talked about the myofibroblastoma. We mentioned that in differential. This would certainly be a differential in this case as well, because the myofibroblastoma falls in that location. And remember, myofibroblastoma of the breast was first described in men, really. So then extramammary myofibroblastomas, and then of course the following that milk line all the way down to the lower genital tract and the buttock as well. I've seen them in the buttock as well, so they can occur there. So coming back to my differential diagnosis for RB1 loss, right? So we've had two tumors, cellular angiofibroma and myofibroblastoma. The other one is spindle cell lipoma. Those are also RB1 loss. They are lost in 50% of pleomorphic liposarcoma, and there's another one I forget now. RB1. You can tell me. Somebody can remind us. Okay, any questions or comments? It's just a neat little 3 spindle cell tumors, which, like I say, inadvertently fell in line with each other. And so it's a good discussion of these bland spindle cell tumors, which if you have good morphology, you can make them out. But, the only thing you can really be sure is a classic schwannoma, perhaps a classic neurofibroma. And there's some other things that you can be. But more often than not, you need a panel of immunohistochemistry. And we talked about that already. Just just think of your myofibroblastic, your fibroblastic nerve sheath, and that will give you guidance with respect to how to proceed. And don't forget the perineurioma, because that often is forgotten as a nerve sheath tumor. There are 3 nerve sheath tumors, and they can be hybrid as well. So it's neat to pick up some of the hybrid features as well. Okay. Yeah, that's exactly what it is, Janet. A nice cellular angiofibroma. Any questions or comments? Whilst I'm trying to pull up my neck.
So with these benign lesions, would I be helping the clinician if I don't have immunos, if I say benign spindle cell lesion, and then maybe I say completely, if it's completely excised, would I be helping the clinician if I just say that?
Yeah,
and I list my differentials.
Correct. That would be perfectly okay. And I understand in Botswana, you don't necessarily have all the immunohistochemical panel, but I would implore you in the setting of if you have some myxoid areas, then make sure you do the MUC4 because that adds a different dimension to the management, okay? Those are very bland, they're very benign looking. And so you know, if you could get a MUC4 into your panel, that would be really nice color. You know, out of all the markers we mentioned, I know you've got an S100 and I know you have Desmond and CD34 and you have Actin, so you have some to work with. You don't have RB1. You don't necessarily need that, but it's useful. But what you should get is MUC4 out of all those that we've talked about so far today. Beta-catenin, I think in abdominal wall, abdomen, you have sweeping fascicles. Sometimes they do become quite difficult with differential diagnosis, particularly in needle core biopsies. So I think beta-catenin will be useful as well. Having a beta-catenin MUC4 along with the basic panels we talked about, that would be useful, Carla. I don't know if you got beta-catenin yet. When I was there last October, you did not. So I wasn't there last. Yeah, I was there last October. Yeah, you did not. So I would say get the beta-catenin and MUC4. And there's some things you can look at your list and you don't use, like NSE. Some people have NSE still in their panels, or they even have Vimentin. Vimentin, sure, you can argue it's useful for distinguishing cervical adenocarcinoma and endometrial adenocarcinoma, but there's some antibodies you can get rid of that you don't need, and you can bring these ones on, which are helpful. I think a low-grade fibromyxoid sarcoma can recur and metastasize and looks very, very bland. So just giving a morphological diagnosis, that would not help the patient and or the clinician. So good question, Carla, and I understand the limitations, and but you can always be smart and think about which ones you need with respect to benign versus malignant. MUC4, I would say you have to have. Beta-catenin, I would say you have to have. Those recur, they can cause problems, and those patients need to be followed up. That's a good question, Carla, and I fully understand the where you're coming from. Go ahead.
No, thank you, Prof.
Most welcome. Any other questions? I was moving to this next tumor once people were thinking of. Okay, this is a needle core now. We now have a tumor that was biopsied, a pelvic mass. This is a young man. He's 19 years old, and this is a pelvic mass. So that's the entire core that's been scanned, and I'm going to take you through it. And you're going to say, "Oh my gosh, another spindle cell tumor." but look at this carefully. Okay, I'll just keep it at medium power, just so that you can appreciate the architecture and the variable components. And then I'll take you on high power. Okay, so you would have seen these more cellular areas, and then these spindle areas, little myxoid matrix, this pale blue matrix. myxoid, and then there's fibrosis here again, and nice spindled areas. And then these cellular areas, just going to go down high power on this, just to show you this. Now we have one of those islands of cellular areas, and I'll let you look at that. And it's probably the highest power I can go. Okay, and those are the two components. And if you look at these little strands here in these areas, you'll see the same morphology here. It's a little crush. That's a little crush. That's a blood vessel.
The age of the patient?
19, and he's a male. Yeah, these little islands all look the same, and I'm going to take you down just to have you feel comfortable that these look similar, but different from these spindle cells. Okay, a little crushed, and some artifact as well. This spacing that you're seeing here is all artifact. Don't pay much attention to those spaces there. These are the cellular areas. And then if I get back on medium power, you can see more of these cellular areas, and then this background spindled little myxoid matrix as well. Okay, what's the thoughts on this one? I'm not giving you an answer now. You have to tell me.
IHC profile, doctor. Is
You
it
want-
ER?
You want an ER, estrogen
Yeah.
receptor. Okay, estrogen receptor is negative. Why did you want an ER? Tell us why, please.
The first thing that comes to my mind is there's hypocellular myxoid tumor with cellular areas. The deep angiomyxoma was my thoughts.
Okay, deep angiomyxoma, and you wanted an ER. Okay, the tumor you're thinking about was typically described in women, usually pelvic. This is
Yes,
pelvic.
of course, yeah.
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 Have they been described in males? I don't know the answer. That's why I'm asking this question.
Oh, okay.
Have you come across it? I don't know. I'm just curious. Just to tell the other people that these are deeply infiltrative. They're very bland looking. They are myxoid matrix. They can have some bands of muscle. And then they also HMG A2 rearranged. That's a high moiety group A2 rearrange. If you have fish for that, it's useful to confirm the diagnosis. There's no other immunohistochemistry that can help you. You can have variable ER like you asked for. That's fine. And you can get some smooth muscle, which is fine. These cellular areas are not a feature of that tumor. These highly cellular areas that we are looking at. So the background, probably deep angiomyxoma might fit. But like I was saying, these are artifacts. These spaces are artifact. They're not real. Okay. Here's a vessel here with some space. So this is just separated from that. So ER is negative. What else did you want?
Okay, so yeah, I was thinking more in line with angiomyxoma.
Okay.
And so ERPR, I think.
Okay. Okay. So both those are
and CD34 too.
CD34 is negative.
Okay.
Okay. That's a good start. It's a good start. You have to attack or target your differential diagnosis with your immunohistochemistry panel. You have to have a morphological list of things that you're thinking about, and then you're going to do your genetic panel to try and help you narrow down that list. And once you narrow that list down, you then go for specific markers to help you identify what the tumor is. That's the way I function every day. I do a genetic panel, and once that comes back, I would then do more specific markers. And then now in 2025, as you all know, if you have access to molecular investigations, then you can use them to help you as well. So we've had deep angiomyxoma, which is the correct term. Remember, the WHO changed that from aggressive angiomyxoma, when it was first described because of the deep infiltrative nature in the pelvis. and they change it from aggressive angiomyxoma to deep angiomyxoma. They're very rare. I've probably seen, I think, 2, maybe 3, and extremely rare. And you have to be aware of that, aware of the radiology, and aware of what the clinician is saying. Your surgeon will tell you this is deeply infiltrative. The radiology will tell you it's deeply infiltrative, but the morphology does not fit the description of radiology and clinical, because it's extremely bland looking and very hypocellular. All right, any other thoughts? Thank you for that. Thank you for that differential. Appreciate it. It helps us talk about the differentials. Any other thoughts? Let's move this along.
It looks like it could fit into the small round blue cell tumor category. And in a patient of this age, perhaps something like a desmoplastic small round cell tumor.
Exactly my thoughts. And in fact, you could get away with just pure immunohistochemistry on these, because these have a Desmond dot-like immunoreactivity, and they also have keratin as well. Now, in the old days, they used to say that NSC was positive, and that was the marker that was used to say that it was polyphenotypic, because you had epithelial, muscle, and then what was known before as neuroendocrine. I mean, we don't believe that NSC is a neuroendocrine marker anyway, but that's what the historical perspective is of these tumors. I think the Desmond dot-like immunoreactivity is very useful. And like I said, you know, knowing the history and knowing that this is a mass, you could suggest a desmoplastic small round blue cell tumor. Confirmation, of course, as you all know, is with demonstration of EWSR1, which is the fusion partner to WT1. So WT1 is the gene on chromosome 11, and EWSR1 is on 22. So this was positive, Janet. We did do the EWSR1, and we signed it out as a desmoplastic small round blue cell tumor. And like I said, both keratin and Desmond were positive. The dot-like Desmond is extremely useful and helpful, very helpful. Last year, I think maybe in last April, and if anybody from Durban, South Africa is here, will remember that case. They showed me a case, maybe in October as well, I cannot remember now. A young man who had a disseminated small round blue cell tumor, and the mass that they biopsied was in the shoulder. And this is the pattern that it had. And we looked at the immunohistochemistry, and we found 5 cells, literally 5 cells with focal Desmond dot-like positivity. And we asked for the EWSR1 and came back positive. Literally, so look very hard for those. And my experience with that is the keratin was positive, but the immunoreactivity with Desmond was what made us sure that it was a desmoplastic small round blue cell tumor. And lo and behold, the EWSR1 came back positive. So that's very useful. So agreed, Janet. Yes. Any questions on this? These, remember, were first described by Dr. Rosai, I want to say in the 80s. And the way they described this was very interesting when you go back to the history. Intra-abdominal small round blue cell tumors with desmoplasia in young males. That's how it started out. And then they discovered that it could occur in women as well. So they dropped the males. So then it was desmoplastic small round blue cell tumor, intra-abdominal desmoplastic small round blue cell tumor. Then they discovered it occurred in the thorax as well. So they dropped intra-abdominal, became desmoplastic small round blue cell tumor. So now, as you know, it's known as desmoplastic small round blue cell tumor. It's a distinct entity, and it's been verified with molecular confirmation. I always admire these great morphologists that we've had in the past who recognize these entities as being distinct and different, and were strong and brave enough and confident to call them based on pure morphology. And then years later, this confirmation of molecular characterization, which you know, just puts it all together, which is nice. And there's several examples like that always quote the malignant melanoma of soft parts, which Dr. Enzinger described and 40 years ago, and how those were confirmed with molecular analysis, so on and so on. But that's me going on my historical quest. Okay, any questions on this? And it's just a nice, lovely example of desmoplastic small round blue cell tumor. We probably see one every 2 or 3 years. They're very rare, and the oncologists know how to treat them, and they have regimes for these. So these are the small round blue cell tumors here. All right. No questions. I think we could do one more, Lydia. I see it's 1:50, so we'll try and put in one more, and we'll see how people do with this one. 37296. 37296. There we go, right at the bottom here. Okay. So this, you can all recognize, this is a 44-year-old woman, and you can all recognize the lung tissue in the background. So this was a lung wedge resection. And then you have these nodules here. Some of them are in the parenchyma. I'm just going to show you the distribution. Wow, look at this one. This is literally either breaking out or breaking into this vessel. Okay, we'll go and look at the morphology. It's hugely cellular, very, very dark. Yeah, it's also very close to vessels. Yeah, I never noticed that so closely before. I always do that when I go back to South Africa and Africa. I'm showing slides and I notice different morphologies. Here, there's some necrosis as well. Okay, so let's look at the morphology. It's very blue. It's very cellular, highly cellular. Okay, I'm showing it to you on higher power so you can appreciate the morphology. And then here as well, you can see the pattern as well. I hope you can appreciate the pattern. Let's just try and look for other patterns. Yeah, there's a little more sort of almost fascicular there. Most of it is sheet-like, but you can see they do look fascicular. All right, she's 44, and these are multiple lung nodules. It was resected by the thoracic surgeon. Any thoughts? Yeah, I'm showing you this vessel again. It's tumor in the vessel.
Could it be a pulmonary artery intimal sarcoma?
That's a great thought. It's a great thought. Pulmonary artery. That Brendan Price. I can see the names.
Yes,
if you don't.
right.
Yeah. Thank you. I appreciate that. That's a very good thought. and it's exactly the reason why I always ask for a differential diagnosis, because when I put this slide on, I never even thought of an intimal sarcoma, but it's great because then we can talk about it a little. Intimal sarcomas, typically, yes, like you say, pulmonary, they occur in the pulmonary vein. Sometimes they grow so extensively you cannot even be certain that they're arising from the pulmonary vein. They involve the aorta, they can even involve the pericardium. But generally, the surgeons would tell you that the pulmonary artery or vein is involved as well. And they can have this morphology. In fact, the intimal sarcomas or pulmonary vein have a varied morphology, can be quite heterogeneous. They can look like this, highly cellular, spindled, even round cells. They can look like UPS, the undifferentiated pleomorphic sarcoma, which can look like anything, literally. They can be myxoid, they can be myxofibrosarcoma-like, and they can even be, nerve sheath-like, peripheral nerve sheath-like. So any of them would suffice, and you have to think about it. Now, the kicker is, and unfortunately, Carla, you need MDM2 to verify that. And you don't necessarily need a molecular tool for that. MDM2, as you know, can be done on an antibody. If you have a good, reliable antibody, you can do that. And it's interpretation that's important for that. So that would help you. So I did not do the MDM2 on this, Brendan, but I can tell you that it is negative. I can tell you that it's negative. So that's a good thought. It's a good start. Is to say a pulmonary intimal sarcoma. And there are, I do have one or two in my slide collections, and I'm sure in the coming months or years we'll come across those. I do have them. Any other thoughts? Okay, let's take this tumor away from here. Let's put it in the deep soft tissue of the thigh. And this woman, she's young, she's 44. And let's say
Hi,
she's
Prof. Hi,
yes,
Prof. I was just thinking, it looks like, you know, those translocation tumors where everything looks the same, but you know it's not benign, you know, like a synovial sarcoma monophasic. I don't know if I'm
you're spot on. You're right. That's exactly what it is.
yeah,
So
monophasic synovial.
yes,
Yeah.
exactly. Monophasic synovial sarcoma. You can get it. And when in my younger days as a registrar resident, we used to use EMA and keratin to make a diagnosis, because you could get focal EMA, which was very useful. Importantly, you may think, could this be a cellular SFT? And these are CD34 negative, because SFT is CD34 positive. So here's another role for CD34 as well. Then you could ask yourself, well, is this a Ewing sarcoma? Some of it looks round. You're all familiar with the poorly differentiated synovial sarcoma, which can look round. And some of this does look round. You can see that. It's very uniform and very round. So you may ask yourself, could this be Ewing sarcoma? CD99, which is a useful marker for Ewing's, gives you a membranous, diffuse membranous, can be positive in synovial as well. So knowing the panel and knowing your differential diagnoses, you can approach those appropriately. Now, we do have FISH, and as you know, X18 is the translocation, and we have SYT, FISH to SYT, and this was positive, but you can get a protein, an antibody to that, and specifically to one of those genes or to the entire chimeric protein, which is very useful. Brigham uses that all the time. So there are antibodies available which can help you in confirming this diagnosis as well. So again, coming back to Carla's question, which is a very, very appropriate question, would you get the antibody for your panel in Botswana, say in Botswana? And how often do you see synovial sarcomas? You have to work that out and decide. But there are antibodies that are available. There's two, in fact, which has been published and proven to be pretty specific and useful that you could use. This was FISH positive, and like Carla said, this is a translocation sarcoma, and this was sitting in the lung because this patient metastasized to the lung. This is a poorly differentiated variant because of the round cells, and you can see necrosis here. And by the mere fact that it's in the lung means that it's highly aggressive as well. Synovial sarcomas, we don't grade them. We don't give them an FNC LCC grading system. Okay, we regard them all as high grade. There's no such thing as a low grade or intermediate synovial sarcoma. Same as angiosarcomas. We don't grade them, nor do we give them a grading system. We just regard them as high grade. Okay. Any questions or comments in the next minute or so? Otherwise, I want to thank you all for joining us here today.